Okay, so I guess we needed a 15-minute break with an hour of anxiety. We're going to get another hour of anxiety now. It was good to have a break between the two, but we have Dr. Anderson Chen, who was working with us about doing an algorithm for anxiety in the elderly. And then we rapidly discovered that that is such a complex topic. There are so many kinds of anxiety in the elderly, and everybody else for that matter. But even to focus on the elderly, we better narrow the scope to just generalized anxiety as a start. And then we're going to work on the other kinds of anxiety in a subsequent effort that we're going to make. But we have put together an update of the anxiety algorithm with the focus on the elderly on generalized anxieties. So Dr. Chen's bio is in the handout. I will turn the chair over to him right away.
Thank you, Dr. Osser. All right. Hello, everyone. What a privilege to be here. Today, I will be talking about an evidence-based approach to psychopharmacology for generalized anxiety disorder, a 2022 update with an emphasis on geriatric patients. We have about an hour today. I plan to talk for about 50 minutes and leave 10 minutes or so for questions at the end. I'd like to thank my dear friend and mentor, Dr. David Osser, for helping me put this program together. This is essentially an update from the last publication of this algorithm for adults. So it wasn't for elderly patients by Dr. Zabuela and the team, and Dr. Osser was the mentor, and was published at Harvard Review of Psychiatry at 2016. The insights that we gather from new evidence since 2016, and also looking back at some of the evidence with a specific lens in elderly patients is what we're going to present here. It is not peer reviewed yet because it is not published yet. The authors have no financial relationships with any pharmaceutical companies. So what you're going to hear in this lecture is we're going to talk about why an algorithm for generalized anxiety disorder in the elderly, looking at comorbidities and other conditions that might change how you think about this algorithm. And I do think this is a really important part of treating anxiety in the elderly. And the algorithm will mention what are the FDA-approved medications. And just because it's FDA approved doesn't necessarily mean it's really good. And just because something is not FDA approved doesn't necessarily mean it's bad. All right. So we'll also mention off-label medications with evidence. We will, of course, talk about the role of benzodiazepines, which is a frequent topic that comes up when talking about the treatment of anxiety. And we'll talk about treatment-resistant general anxiety disorder cases, how one might think about that. And we'll end on medications that we think one might avoid using to treat general anxiety disorder in the elderly. So let's talk about generalized anxiety disorder in general. So this includes adults and elderly. It is usually a chronic disease course and debilitating. Now, the anxiety as it comes about when you're in young adulthood and as you transition into the elderly phase, that anxiety might differ a little bit. I always say the elderly patients are perhaps the most resistant patients, so they might have developed a lot of coping skills along the way, and the anxiety flavor might change a little bit to now being really concerned about your own health, fear of falling, what we call basophobia, things along those lines. You frequently will see anxiety disorders in the primary care setting. And we really hope our algorithm provides a space for those primary care providers to come, take a look at the evidence, and deliver a really evidence-based approach for the patient, thinking about the patient's goals, and based on your relationship with the patient. Be flexible with this algorithm. And I really do think this is the part where you can really decrease morbidity and hopefully avoid mortality. What do I mean by that? in the elderly, if you don't treat the anxiety, and now we're assuming it's generalized anxiety disorder well, you could really have the patient not be as active as possible. All of the baseline medical conditions would deteriorate. And frequently in the elderly patients, there might be medical insults that happen. And if their baseline is poor, you really are not doing them a favor, and it can be really dangerous. 7 million Americans are hypothesized to be suffering with generalized anxiety disorder. Now let's look at the elderly. In the elderly, the prevalence of generalized anxiety is about 6 to 9%, but this is likely underreported. And the reason is because some patients might not have insight into their own anxiety. They might feel, I've been this way for decades, it's not a problem. And for those situations, I would encourage you to really rely on collateral information. Talk to the spouse or whoever is living with the patient to understand a little bit some of the symptomatology that's happening. Get a 360-degree view of the patient. It's really important. And sometimes, even if the patient doesn't subjectively say their anxiety, they can have physical symptoms. GI symptom is a common one, and you might see that more in a patient population where there might be a lot of stigma related to anxiety, for example, in the Asian population. But of course, you can also see tremors and palpitations and psychological symptoms like apprehension about major and minor concerns. Again, in the elderly, there tends to be a shift towards focus on their own health, and understandably so. So our algorithm is a psychopharmacological one, but it would be remiss of me to not mention that psychosocial intervention is extremely, perhaps the most important thing one should do. It should be at the start of your thinking and all the way towards the end. And you are always coming back to it to make sure you're not missing a psychosocial intervention. But our algorithm focuses on the pharmacological approaches. Now, you should reference our algorithm once you and the patient believe that medication is desirable. And of course, you've diagnosed it's GAD. And what this means is perhaps the symptomatology is so severe that psychosocial intervention alone was not helpful enough, or that the patient is really suffering and you want to use medication to create some room for the patient to breathe. I will say that the majority of patients do prefer non-medical treatments. I think the elderly patients are really cognizant about their own health, what they're taking, what they're not taking. If we look at the medications for generalized anxiety disorder, there are ones that are FDA approved. Now, again, just because it's FDA approved, it doesn't mean it's necessarily good for the elderly population. So for the SSRIs, there's escitalopram and paroxetine. For the SNRIs, there's venlafaxine and duloxetine. For the benzodiazepine, there's alprazolam, and then there's buspirone. We will discuss all these medications, as well as the off-label medications, such as the other SSRIs. We will talk about hydroxyzine, pregabalin, gabapentin, agomelatine, which is not available in the United States, but our algorithm is referenced internationally, so we did include it here. And perhaps your patient lived overseas and has heard about this medication and might ask you about it. We'll talk about the use of lavender oil, which is available over the counter. And we're not recommending benzodiazepines, and I will go into that in more detail as we go along. I think a good place to start is being familiar with the DSM-5 criteria for generalized anxiety disorder. And the reason is because the papers we do reference, when they include patients into the study, they made sure those patients fell into these criteria. So we want to make sure your patient would be applicable to those studies. So I think it is noteworthy just to go over it really quickly. Excessive worry occurring more days than not for at least 6 months. The worry is difficult to control and is associated with 3 or more of the following: restlessness or feeling keyed up, being easily fatigued, difficulty concentrating, being irritable, having muscle tension, and lastly, sleep disturbance. And this is obviously causing significant impairment. So once you diagnose GAD, you evaluate, and you want to go look for other comorbidities. And I want to say it's entirely appropriate to be thinking about the comorbidity and GAD treatment at the same time. The comorbidities that we're going to talk about is not all inclusive because I only have an hour, and when we do submit it for peer review, there's probably a word limit, so we can't go on and on. So we talk about sleep disturbance, neuropathic pain, active substance use, major depression, bipolar mania, and lastly, PTSD. Some other that I'm mindful is really important, but we don't go into, is perhaps a new onset of a cognitive disorder that could frequently have symptoms of anxiety. You want to be thinking about that. Perhaps there's a medical condition that involves respiratory depression, being difficult, finding it difficult to grasp for air. That could come across as having anxiety. So you want to be mindful of those things. But these are the specific comorbidities that we'll be touching on. And I will also say, as you progress through the algorithm, if the first med doesn't work, the second, third doesn't work, the chances of the next medication working is perhaps it just continues to decrease. And you might think about the comorbidities. You want to keep going back. If those are just not well treated, treating those might help with the overall well-being of the patient and maybe even help with the anxiety. So let's go into sleep disturbance and insomnia. So there are a lot of possible contributing causes. A good place to start is you might want to consider like a sleep study. And this is particularly important because some of the medications we frequently give to patients with insomnia might be dangerous if you have OSA and you're not treating it. And you also want to be mindful that some treatments can worsen insomnia, like the use of SSRIs and SNRIs. And in these cases, some of the more sedating agents like hydroxyzine and pregabalin might be preferred over the use of SSRIs and SNRIs. You might even add trazodone to your SSRI treatment. Another comorbidity, oh, by the way, these comorbidities, it's not like like the first one I mentioned is more important than the second one. These are all really important. You should be thinking about. The next one is pain. Pain is, of course, complex, and there's many different subtypes from acute to chronic, which kind of changes to central, as there's inflammatory, musculoskeletal. But here we're just talking about neuropathic pain. There's prominent neuropathic pain, and by the way, pain is quite common in the elderly as the body goes through wear and tear. Pregabalin has an indication for neuropathic pain, and gabapentin does not, but it's frequently used for neuropathic pain. So you might consider pregabalin rather than an SSRI. But if you do that, just be mindful your patients might discontinue it because they're not tolerating it. It's been associated with falls. They might have Googled it and seen it. The other comorbidity you might want to think about is active substance use disorder. It's quite common in patients with anxiety, 15% comorbid. They might be self-medicating. And in those cases, they're taking medications to calm themselves down. You might want to avoid a benzodiazepine and avoid other medications that's prone to abuse like pregabalin and gabapentin. But the flip side is true. What if they're taking a medication that's like really activating? Perhaps that's causing that's contributing to the feeling of anxiety, and that's another really fruitful target to go after in the treatment of the patient. You might want to consider, is there concomitant major depression? Because major depression and generalized anxiety disorder can coexist, and they're distinguishable. And we do know that MDD with comorbid anxiety responds much less well than without anxiety. Hydroxyzine and pregabalin add-ons could be tried in these situations. Quetiapine can be effective, but there is considerable side effects, right? It's anticholinergic, there's QTC concerns, the black box warning, extrapyramidal symptoms. Aripiprazole augmentation of an SSRI could be effective as well, but again, it's an antipsychotic, and many of the side effects I had mentioned, you want to be mindful. We would avoid benzodiazepines, and benzodiazepines can sometimes even worsen the neurovegetative symptoms. And I will go into more detail later about the avoidance of benzodiazepine. Another comorbidity you want to think about is the presence of bipolar depression. Rates of generalized anxiety disorder are higher in bipolar patients compared to those with unipolar. And I think we know, and Dr. Osler has talked about that pretty extensively in his talk, but you should just avoid the use of antidepressants. For bipolar depression, you should consider, and again, Dr. Osler had talked about this, quetiapine, lurasidone, cariprazine, lumateperone, or a combination of lithium and lamotrigine. For the GAD comorbidity, you might consider adding hydroxyzine or pregabalin. Quetiapine was again found helpful in 20 out of 27 studies of bipolar patients with anxiety, but it has a lot of the side effects that I had mentioned earlier. Bipolar depression, you also want to think about bipolar mania. It shouldn't come as too much of a surprise that manic patients have high rates of generalized anxiety disorder, and response to lithium and anticonvulsants are typically reduced. Valproate was effective when compared with placebo in a small study of men with comorbid generalized anxiety disorder. So you might look at that favorably. Quetiapine, again, may be preferred here. If the patient presents with anxiety in the context of a mania with mixed symptoms, you might consider valproate over lithium in these situations. Lastly, you want to consider the presence of post-traumatic stress disorder. Prazosin has been studied a lot. Add-on for nightmares, disturbed awakenings, it's well supported. You can look at the protocol that was referenced earlier in terms of how one might dose it. And I will say, if you're able to help them sleep better, and that goes with the insomnia I had mentioned earlier, the effects can really be quite huge. I have a seven-month-old daughter, and I frequently don't sleep as well as I'd like. And I do feel the effects being quite pervasive. So helping with the sleep can be really nice. And benzodiazepine here again is not effective. A big part of, so I did residency at Harvard South Shore, so I have good experience with helping many patients, veterans with PTSD. And I do know a big part of PTSD is helping the patients learn how to cope, how to trust society again, going through the therapy. Basically, learning is a big part of it. And studies have shown patients with PTSD on benzodiazepines compared with patients with PTSD not on benzodiazepines. When they go through therapy, those who are not on benzodiazepines do much better. And that's not very surprising because you don't learn as well when you're on the benzodiazepine. So after you've considered the comorbidities, you should ask the question, has the patient tried an adequate trial of an SSRI? And if not, we would suggest the use of escitalopram or sertraline. So in general, SSRI is a really good, is a decent treatment for generalized anxiety disorder. It's considered widely by many as the first-line medication for uncomplicated cases of generalized anxiety disorder. And the FDA-approved medication would be escitalopram and paroxetine. Sertraline has a comparable efficacy in 3 randomized controlled trials. Citalopram, if you do use it, you want to be mindful of its QTC prolongation effects. And the overall effect size of SSRIs has a Cohen's d of 0.36, so it is modest. Now let's take a look at the use of SSRI in the elderly. There are papers that specifically look at this, and we do look at that favorably and helps us answer the question, what might be more helpful. Well, there's a randomized controlled trial of 179 patients with generalized anxiety disorder over the age of 60. 85 of them were treated with escitalopram, and the mean age was 71.1 for 12 weeks. And the doses range from 10 to 20 milligrams. Results show that escitalopram was superior to placebo, and the effects was impressive, 0.93. And the benefits can be seen within 4 weeks. It was well tolerated. The dropout rate was 3%. Fatigue and somnolence were some of the more common adverse effects. And I will say, if your patient has concomitant dementia, there is also very, very good evidence for the use of escitalopram. The next medication that has evidence in the elderly is sertraline. In one randomized controlled trial, 46 patients older than 60 with generalized anxiety disorder, 21 patients received 50 to 100 milligrams of sertraline daily. The mean age was 67. And 25 received 10 to 15 milligrams of buspirone daily. During an 8 weeks follow-up, sertraline was shown to be helpful for generalized anxiety disorder symptoms as early as 2 weeks into treatment. And similar to escitalopram, if your patient does have concomitant dementia, there's also some evidence for its use to help with behavioral and psychological symptoms in dementia. There are issues with SSRIs. Their sexual side effects is something you want to be thinking about. Just because your patient's more mature does not mean that they're not interested in sex. It's tough to discuss. It doesn't really remit with time. And frequently, our patient population are on other medications that might be impacting their sexual function, like antihypertensive. So this is a problem that is not trivial. You want to be mindful of bleeds. GI bleeding is 9 times more common over 3 months if you're on an SSRI, and ibuprofen are similar compared to control group not on an NSAID. But it can be mitigated if patients are on omeprazole or similar. Now, this is pretty significant. I frequently encountered this in my fellowship just in 4 months, where I have patients with anxiety and then also have some form of chronic pain, and they take a nightly ibuprofen. So you do want to let them know about the risk. Perhaps they might consider other pain medications like Tylenol. Hyponatremia is also a risk you want to be mindful about in the elderly, particularly if they are currently medically really unstable. They have a past history of hyponatremia and even recurrent ones, so that's very concerning, or if there's recently an insult to their renal function. So these are some SSRIs we don't really recommend. Citalopram, the potential to prolong QTC is something you should be really mindful about. So if you do decide to use it, you want to be making sure you're cognizant about this and checking the electrocardiograms. Paroxetine, it's really anticholinergic and antihistaminergic. And in our patient population, that's pretty problematic because it might lead to confusion, which can worsen anxiety. And it's not good for their overall cognition. And there's significant risks of drug-drug interaction due to cytochrome P450 interaction. There's also strong sexual side effect. And this last part is important. There are quite severe withdrawal reaction if the dose is stopped or omitted. And this does happen more often than you think, regardless of the environment the patient is in. So you could imagine if the patient is dependent on others to give them medication, right? What if the person who's giving medication, there's a change of shift, there's a delay, something happens, which is really not, is quite common, they might miss their dose. What if they are preparing their own medication and then they have a mix-up, or perhaps they ran out of medication, they're calling the pharmacy, or they have to first leave a note to us on Epic or something, and then that thing is missed, and then they miss the medication. These things can happen. And for that reason, we don't recommend the use of paroxetine. So if medical and sexual side effects are not tolerable, you might consider buspirone and hydroxyzine. So let's talk about that a little bit more. Buspirone. So buspirone is typically a medication in adults where we don't necessarily expect a strong effect, but that could be quite different in the elderly, particularly, let me put it this way. So you might see generalized anxiety disorder in a patient who was always anxious all their life, and perhaps they've developed a lot of amazing coping skills, whether that's through their work, but then they retire. So that coping skill is gone, or perhaps they had a medical insult, and all those safeguards that were there were taken out, and now a lot of these anxiety symptoms are coming out. And they really haven't been tried on a lot of medications. They're not on a lot of what we would consider heavy hitters, like benzodiazepines or quetiapine. Then buspirone, I would expect that there's a good chance of it working. Effective at 30 milligrams daily. It's useful in placebo-controlled trial in abstinent anxious patients with alcohol use disorder at an average dose of 50 milligrams daily. There's no abuse potential. There's a good side effect profile. There's little overdose toxicity, no cognitive or psychomotor impairment, which is really important for us, and there's no sexual side effects. It is FDA approved, but you should be mindful that there's only one placebo-controlled trial to confirm its efficacy. But we really believe it's worth considering given its benign side effect. Especially if you look at the manufacturer labeling, there isn't even a dose adjustment needed for the elderly population. You should be mindful that sedative effects are more likely when the daily dose exceeds 20 milligrams. You might use that to your advantage. But you should also be mindful patients could have insomnia, jitteriness, nausea, and headaches. The typical target dose you're going for in the elderly ranges from 25 to 30, and it can be titrated up to 45 milligrams daily if necessary. You want to be mindful of the bioavailability might increase 14-fold in patients with hepatic impairments and 2-fold with renal impairments. Hydroxyzine is another medication that we would recommend in this context. It's a good option if sedation might be helpful for the treatment, especially if insomnia is prominent. In 5 randomized controlled trials studying generalized anxiety disorder, hydroxyzine was found to be safe and efficacious compared to placebo at approximately 50 milligrams total daily dose. However, we are cognizant as antihistaminergic, which is not ideal, with less affinity for muscarinic, serotonergic, dopamine, and alpha-1 receptors than others. But it is more effective than placebo at odds ratio of 0.45. There's no abuse potential or withdrawal syndrome. It's sedating like benzos, but there's less cognitive impairment compared to benzos, and then there's no sexual side effects. And it really is a better choice compared to what other medications might be prescribed, like the Z drugs, quetiapine, olanzapine, things like that. Usual dose might be 10 to 12.5 mg BID and 25 mg HS, but always I would encourage trying a lower dose because it might be better tolerated in the elderly, and you don't want to use more than you need to. And it's also frequently used as a PRN because it has a rapid onset between 15 and 30 minutes, half-life of 3 hours, and duration of effect total lasting between 4 to 6 hours. You also want to be mindful of QTC prolongation, so it's something you want to check, and the maximum daily dose now is 100 milligrams. So in the elderly, considering the studies showing at what dose it worked, we recommend maximum dose 50, minimize the use because we're cognizant of the anticholinergic and sedative effects can be problematic. And of course, you want to avoid this in patients with dementia because of kind of these anticholinergic side effects. So you might, at this point, try another SSRI. So if you had tried escitalopram, you might try sertraline, or another 3B option, which is here that we talked about. but you could also consider duloxetine. So duloxetine is FDA approved with comparable efficacy to SSRIs. It's a favorite SNRI compared to venlafaxine because it has a little bit less blood pressure impact. It also has lower rates of sexual side effects, at least compared with paroxetine. Be mindful, it's contraindicated in patients with liver impairment, so you want to monitor the LFT, and you want to be aware that this is a strong CYP2D6 inhibitor. And if you do prescribe it, in addition to checking for drug-drug interaction, tell your patients about the risk of perspiration and infrequent urinary retentions. The effective dose is at 60 to 120. There's really no advantage to going to a higher dose. Common adverse effects, I think we're quite familiar: nausea, dizziness, dry mouth, fatigue, somnolence, and constipation. I frequently see it prescribed when there's concomitant pain. It's FDA approved for pain for sure, in diabetic neuropathy, chronic musculoskeletal pain, and for fibromyalgia. But in these studies, the patients with depression and anxiety were generally excluded. So if you look at the effect on pain in depressed patients, the effect size was only 0.115 in one study and 0.13 to 0.25 in another. So, you shouldn't be that surprised if the pain didn't improve that much if your patient has depressed symptoms. Here, we then recommend a third medication trial. You might try another of the medications we had mentioned before: pregabalin, gabapentin, agomelatine, lavender oil. So pregabalin, it's approved in Europe for generalized anxiety disorder. There's 7 positive randomized control trials versus placebo. It's recommended first line in international guidelines. But it isn't approved in the United States for generalized anxiety disorder. It's been rejected twice, perhaps because of the small effect size in the US studies. But it is comparable when compared to SSRIs. There is rapid onset. It does help with sleep. So if insomnia is prominent, this is certainly a medication you might think about. And also if neuropathic pain is prominent, a medication to think about. There is a dose-dependent effect. Greater than 300 milligrams daily tends to be more effective. And it can help with anxiety in the elderly. You just have to be mindful of falls, somnolence, dizziness, increased risk of fracture. So these are certainly things you want to be upfront and telling your patients about. There is a study of its use in the elderly, and an 8-week randomized control trials of 273 geriatric patients with a mean age of 72, pregabalin dose range of 150 to 600 milligrams daily. And it was shown it helped GAD symptoms within 2 weeks of treatment. So again, when there's these studies in the context of elderly, we do value that, and we want to share that with you. In regards to pregabalin versus gabapentin, we speculate that gabapentin can be used to replace pregabalin if you somehow choose to do so. They have similar biological effects. But there are no controlled studies of gabapentin in GAD, but it is frequently used off-label as an anxiolytic. We do know that it's effective for preoperative anxiety. There's another trial looking at gabapentin at 300 milligrams and 900 milligrams, and the results showed superior to placebo for anxiety symptoms in 420 breast cancer survivors. So there are these peripheral evidence that suggests it might be helpful for anxiety. And as noted earlier, you want to be mindful of its abuse potential.
So and if you just want to put that on speakerphone and record on this thing, which
oh, I can do that. You guys going somewhere?
We lost Dr.
Cool.
Please mute your microphones. Thank you. So the next medication we would talk about is agomelatine. It is an alleged antidepressant that blocks serotonin 2C receptors and stimulating melatonin receptors. There are 20 RCTs in depression with an overall effect size of 0.24. It wasn't that impressive. Did not do well in studies in the States, so it didn't get FDA approval. and it's not available here. There are studies of it in GAD, 5 RCTs that shown its efficacy in GAD patients, including 2 studies that were 12-week long, as well as a 6-month trial. The same team by Dr. Stein ran a meta-analysis of the trials that they've done, and they showed a number needed to treat, 3.1. I'll be honest, I don't have experience with this medication, but there's the evidence. It's comparable to escitalopram, 10 to 20 milligrams, where you saw a 61% response rate for those on agomelatine and 65% response rate for those on escitalopram. It's said to be helpful for sleep with minimal side effects. In agomelatine, if your patients ask you about it because they've been overseas, you want to be mindful of hepatitis, because in all the studies they've done, there were 6 patients with liver enzyme elevation, but it all went back to normal when they stopped the drug. I think the highest was like 10 times upper normal limits. So you want to use in caution in patients with significant hepatic burden. You might also consider lavender oil. Oh, by the way, these medications that we list in each note we favor them equally. It's not like one's over another. We don't really have evidence to say that. For lavender oil, there are 5 studies in generalized anxiety disorder. One was 6 weeks, 4 were 10 weeks. In the 2014 German study, in 539 patients, they found efficacy in comparison with placebo. The optimal dose was 80 to 160 milligrams daily. It was very well tolerated. It's comparable to 20 milligrams of paroxetine, they say, in the 2014 study. And it's marketed under the brand name Selexin. It's available over the counter. So if your patients are taking it, or if they somehow have their hands on it and they tell you it's helping, they might not be wrong. And we're now familiar with some of the evidence for it. So at this point, if the anxiety,
Just hit record.
yeah. So again, please, everyone, make sure you're muting yourself for the duration of the talk. Thank you. So at this point, if the anxiety is still not well controlled, you might think about this as a treatment-resistant case. And I think in treatment-resistance case, it's really important you go back and look at the comorbidities or other contributing factors to the patient's anxiety. Look at some of the non-pharmacological approaches that might help. And it's also possible during this entire course of treatment that new comorbidities has come about.
Very artistic.
So for treatment-resistant cases, we recommend venlafaxine, quetiapine, risperidone, aripiprazole, and ketamine, and we're going to go over them. So we'll start with venlafaxine. So we think it's reasonable here. We feel like duloxetine is probably the better choice if you haven't tried it. Remission is most likely at a maximum dose of 225 daily. We know there's efficacy for its use and maintenance. In a little bit, we'll talk about why it's not the favorite choice. It's in comparison with escitalopram and placebo, discontinuation due to adverse effects from venlafaxine was 13%, while placebo and escitalopram were like 5%. Common adverse effects: dry mouth, drowsiness, headache, increased sweating. So although it is FDA approved for GAD, for the elderly patient, we lowered it to note 5 because of the side effects, and we think it's not something we want to tolerate, and it's not more effective than SSRI. So what are some of the side effects that I'm talking about? Well, the risk of hypertension is something you want to be thinking about, and uncontrolled hypertension, it can really impact the overall health of the patient, especially when you're talking about strokes, cardiovascular risk, vascular dementia. Those are significant insults. There can be severe withdrawal reactions if a dose is missed, just like paroxetine, maybe even more severe. And I had talked about how that's a really true risk in our patient population. There's also increased risk of non-fatal strokes compared to SSRIs over 1 year of use. There's increased risk of deaths from overdose compared with SSRIs. So for those reasons, we lowered it to note 5. Another medication that's frequently used, shown to be an effective monotherapy for generalized anxiety disorders in several randomized controlled trials, is quetiapine. But we don't recommend it in the first node of the algorithm because of the side effects, metabolic side effects, severe sedation, association with QTC prolongation, not to mention extrapyramidal symptoms, the black box warning for the antipsychotic. So if you do use it, you want to be conscientious of these things. Take caution to monitor xerostomia, sedation, dizziness, and constipation. Risperidone. 2 studies have assessed risperidone's role as an augmentation therapy for anxiety, both of which found the medication to be effective. Dose range was 0.25 to 3 milligrams daily. Again, we put it in node 5, mainly because the side effect profile of an antipsychotic. And for risperidone, there's also the concern of cardiovascular effect a little bit more so than other antipsychotic. You might want to be mindful of that. Ketamine, 3 studies, total of 44 patients, all suggested ketamine to be helpful and anxiety symptoms improve within the week. Some of the more intolerable side effects, you might think about hypertension, and dissociative symptoms. But it is a big commitment for the patient to get the infusion with transportation. But considering the overall evidence and the side effects, we didn't feel like it belonged really high up in the node, so we have it at node 5. So now let's talk a little bit about the medications we recommend against, which are olanzapine, benzodiazepine, dilazidone, and vortioxetine. So we'll start with olanzapine. You might have seen it used. Polak and colleagues investigated olanzapine as an augmentating agent in generalized anxiety disorder, but the results show it is not better than placebo on HAM-A score. Given olanzapine's significant metabolic and anticholinergic risks, and the study, we don't recommend it. We don't think the risk outweighs the benefit. Yeah, sorry, the benefits outweigh the risk. So now let's talk about benzodiazepine as an option. It's been talked about a lot. They are the most prescribed anxiolytic agents worldwide. So perhaps a good place to start is, why is it prescribed in the first place? Well, alprazolam got FDA approved for generalized anxiety disorder at the time of DSM-3. Improvement can be rapid. Clonazepam, which is one of the long-acting benzodiazepine, has been used to improve symptoms while waiting for an SSRI to work. And you can see both somatic and psychiatric symptoms to improve with the use of a benzodiazepine. So, perhaps that's fine in the general adult, but here we're focused mainly on the elderly. So in the elderly, it's frequently prescribed. So of the elderly being prescribed medications annually, 8.7% of them would be on a benzodiazepine. And amongst those who are prescribed a benzodiazepine, about a third of them will start using this medication chronically. And frequently, it's not necessarily because it's helping their anxiety, but it's more that you really can't get off of it. And you probably have had the experience of the patient coming to you and asking for more. If they are on a benzodiazepine, you want to be cautious of respiratory depression when combined with opioids or other respiratory depressants. There are concerns about sedation, like we talked about. Perhaps you were using it to that effect, to your advantage. There's concerns about memory impairment. I think short-term concern on memory impairment is well known. The long-term use, whether it's associated with increased risk of Alzheimer's disease or other dementia. The latest study by Dr. Osser suggested probably not, so that's in contention a little bit. But the short term, I don't think people would argue too much about that on its effect on cognition. And then there's also the concerns on psychomotor dysfunction, especially falls in the elderly, and subsequently increased risk of fracture. And those can really take away the independence of the patient and are really significant insults for them. So you want to avoid that. And the use of benzodiazepine, I will also add, can also get in the way of non-pharmacological approaches that we frequently use in the elderly, what we call behavioral activation, trying to add more structure in their days, things like that. Benzodiazepine, because of its neurovegetative fueling of those symptoms, can get in the way. And you also increase the risk of car accidents. And car accident is a big deal in the elderly because it frequently calls into the question, are they able to drive? And for many patients, they do want to try to hold on to that when it's appropriate and safe to do so. But if they had a car accident, it sometimes gets called into question. 40% of patients on benzodiazepines will develop tolerance or dependence or rebound withdrawal. Latest evidence suggests that anti-anxiety effects and GAD disappear within weeks. You want to be mindful of respiratory depression, especially in patients with sleep apnea. There is an FDA added black box warning in 2017 about combining it with opiates can be fatal. The FDA at 2021 also sent a warning letter to prescribers about the risks of abuse, misuse, addiction, physical dependence, and withdrawal reaction. So there's a lot of cons about it that are out there. And there are no well-established psychopharmacology interventions to help with discontinuations of benzodiazepines. And we frequently find ourselves in the situation of how to help the patient come off the benzodiazepine. And that's really hard to do. So it's perhaps better to make sure we don't put more patients in that situation. And of course, you want to avoid it in patients with substance use disorder. The next two medication we talked about is really because we feel like the evidence is just not there. One is vilazodone. There's a meta-analysis of 3 RCTs with a total of 844 patients who received vilazodone compared to placebo. And the results suggest it is better than placebo, but even the review called for further investigation because the effect size was quite small and there were significant adverse effects compared to placebo. If you're curious, in the RCTs, they use 20 to 40 milligrams daily. Vortioxetine, it's quite inconsistent evidence. There's 2 meta-analyses showing it is not better than placebo for GAD. There's 1 meta-analysis showing it is tolerable as placebo, but less efficacious than agomelatine and venlafaxine. So we don't recommend those 2 medications yet, but I'm interested to see where it goes. So I'll conclude with some final remarks. The first thing I will say is I won't be surprised that if our presentation of the evidence triggers a reaction from you that doesn't necessarily 100% match our recommendation. And for me, this isn't peer review, so I'm not too surprised, but at least I'm triggering a reaction that is based off of evidence. And I think as long as you know the evidence and you talk to your patients about what their treatment goals are and come up with a good solution, for me, that's perhaps a win. You would recognize that we didn't suggest an augmentation therapy. And the reason is because in the elderly, we're trying to avoid polypharmacy. And the studies on augmentation therapy hasn't been that impressive enough yet to compel us to specifically recommend augmentation therapy. I will say in the usual studies of algorithms, if you use it, there's better results when time is spent educating users and accurate use and educating patients about the reasoning involved in these care decisions. And in my own practice, I feel like when I know the evidence, I also gain the confidence of the patient, and overall, it does help with patient care. But it's really important that you recognize that this algorithm should not be followed rigidly. You want to use your own clinical experience and the relationship you have with the patient. Be mindful of what kind of setting you're practicing in. And special consideration should be given for individual patients. So I am at time, so I will stop there and kind of go over some of the questions. I think I have to.
Okay, thanks very much, Anderson. Fabulous job. And we have a lot of questions. I hope we can get to some of them. And again, maybe during lunch and other times, you can try to answer some of them in the chat for people. But let's see, how can I pick from all these questions? Whew. what would be particularly, many of these questions you answered in the course of completing your talk when people were rushing in with the questions early on, but you hadn't covered those issues yet. But let's see. Here's a good question I want to bring up. Why recommend hydroxyzine as one of the second line options when it's a potent antihistamine and can produce weight gain as well? So, and yes, we discussed that, whether we should include it as an option for those very reasons. What would you say?
Well, I will say weight gain is not always bad in the elderly. You frequently have patients who are perhaps the BMI is too low, and that could work for your advantage. But I think it comes back to the point of this algorithm is flexible. So if your patient is now having memory troubles or they're frequently confused, then the anticholinergic effect becomes really salient, and you would want to avoid it. Yeah. So those are valid concerns, but at the same time, we feel there are much heavy hitters that could be prescribed and not as good for the patient. And if you're just very early on and you want to try something, we think it's worth a try. At least that's my perspective.
Yeah, we've debated whether to knock it down as a second line option for the second or third trial rather than having it up there at the first. But on the plus side, it had 5 controlled studies. Not many drugs do, but they weren't in the elderly, which brings up another question, which is, did we discuss all the studies that are actually in the elderly? Are there any more that we could have mentioned, or is most of what we discussed extrapolations from younger patients? And I think the answer is yes. You discussed all the studies we could find, and we did as much extrapolating as we thought reasonable, understanding the issues that the elderly have. But would you like to add anything to that?
No, it's hard because there's just not that many studies. So when there are studies, we do try to highlight it, and I think we did a pretty thorough search.
Okay, somebody said SNRIs can be nasty medications to use with the elderly, and we recognize that as well. That's why we had it in the 5th node as, you know, a 5th resort after you've tried other things. We knocked it down that was one of the points that we did wind up covering in the talk when you got to it, which is that we had it higher up in younger patients, but knocked it way down. Now here's a point. Someone said lavender oil is an endocrine disruptor. Well, I didn't know that. Do you know anything about that? It seemed to be well tolerated in the German studies, but maybe we could look into that and find out where that statement's coming from, and if that would affect our recommending it. We're only recommending it as a fourth, in the 4th set of options after you've done the more standard things. Let's see. A point is made that when you were going through the comorbidities and you got to PTSD, you mentioned prazosin. And the point was made that prazosin can cause syncope and blood pressure problems more in the elderly, presumably. So would you still use it for PTSD with nightmares and all that in the elderly, given that consideration?
I would, and we know that if the blood pressure at baseline wasn't well controlled, the response to prazosin is more robust. But frequently, it's a conversation with the PCP, and a lot of the PCPs, the general attitude I've received from them is they're not too concerned about prazosin dropping the blood pressure too much. And if you're going low and slow, I frequently find it to be tolerable. Of course, medicated, none of them is perfect, but especially if the PTSD is not well controlled, prazosin is really helpful. It's a conversation of risk benefits. but the points are well taken.
Yeah, Prazosin does have 2 studies for, as you well know, because you're co-author of that algorithm, but it is being used for agitation and dementia in 2 studies. That it was well tolerated and seemed to work well. And we have it as a 3rd or 4th line option in that algorithm. So, I mean, use in the elderly is not to be ruled out,
Right.
but yes, you have to be much more cautious.
I will also ask the benefits, and in that study by Dr. Wang at University of Washington, the positive results were seen within a week.
Yeah, work quickly and for the agitation to dementia. We need more research on that though, but it's
Yes.
interesting. Now, the next question is, how is QTC prolongation risk assessed? And it's a correlated and comparable question. How do we screen for hyponatremia in elderly people taking SSRIs? What's the standard of care for addressing that potential risk?
Well, I checked the records, and the EKG is old, or if significant incidents have happened in between, I order another one. The same is true with sodium levels. If there typically is like a sodium level within the past 3 months or so, I don't necessarily go check for another one, but having a baseline is important, and checking it again after you prescribed it is very important as well. And the same is true with EKG.
And is escitalopram less likely to prolong QTC than citalopram?
It is by about half.
That's right. It has been clearly shown in studies that were the FDA required of the drug company at the time. They wanted studies of different doses of escitalopram and citalopram versus a control of one of the fluoxetine antibiotics, which cause QTC. And escitalopram did not prolong it up to the maximum PDR dose of 20. So FDA didn't make any change in recommendations on it, but because of the QTC prolongation with citalopram occurring at 60 and even at 40, they changed the requirement that in the elderly, you can only use 20 of citalopram. So yes, there is a difference. Okay, we've run out of time and we're ready for our next speaker.